Peggy McManus is the president of the National Alliance to Advance Adolescent Health and the co-director of Got Transition. It is a federally funded national resource center on transition. Ms. McManus has over 25 years of experience directing national and state projects on child and adolescent health. And these research and policy projects have addressed healthcare transition, public and private health insurance, the Affordable Care Act, integrated primary and behavioral health, patient-centered primary care, and pediatric workforce issues. Ms. McManus has worked for the last few decades as a consultant with the AAP, working on child health financing and Medicaid. Ms. McManus has a master's in health science from Johns Hopkins School of Public Health. Peggy will be leading us through a presentation highlighting current coding and reimbursement procedures with respect to healthcare transition services. Peggy, we're unmuting you now, so you can go ahead and start in with the presentation. Please feel free to let me know when you need the slides advanced.
Wonderful. Thanks so much, Maya. And thanks also to Sharon Fleshfresser for your leadership in Wisconsin transition activities. I also want to thank all of you who are attending this webinar today. I think of a lot of things one can do within 1 hour's time, and we appreciate that you're here listening about transition payment strategies. So if you wouldn't mind going to the next slide, Maya. So I have no disclosures today, and as Maya said, the National Alliance operates Got Transition, which is a cooperative agreement funded by the Federal Maternal and Child Health Bureau at HHS. And I also want to be sure that you understand that the Academy of Pediatrics has a coding hotline, which is available to assist with any coding advice you have for specific patient services. Thanks. Next slide. So today, the learning objectives for this session are to discuss particular transition payment barriers impeding progress on transition, to review relevant CPT codes that can be used for transition, to look at future value-based payment options for transition, and finally, to review our Got Transition and Academy of Pediatric resources that are pertinent to transition payment. Next slide. So as many of you know, the goal of transition is that it should be an integral component of preventive, primary, and chronic care for all adolescents and young adults. And the foundation from which this goal comes from is from the 2011 clinical report on transition that is based on the consensus of 3 major professional organizations from the Academy of Pediatrics, the Academy of Family Physicians, and the American College of Physicians. In addition, the National Committee on Quality Assurance's patient-centered medical home standards affirm the importance of planned transitions of care. And in 2015, the Federal Maternal and Child Health Bureau set out a new performance measure on transition for youth with and without special health care needs. Now, those are the goals, but the reality in Wisconsin, as it is in the United States, are that the vast majority of youth with and without special needs are not receiving transition planning guidance from their healthcare providers. So although Wisconsin is doing a wee bit better, you've got 80% of parents reporting that their youth with special needs who are ages 12 to 17 did not receive transition planning, and 82% of those without special needs did not receive transition planning in Wisconsin. And this is new data from the 2016 National Survey of Children's Health. And going forward, you'll be able to track improvements in your transition performance over time. Thank you. Next slide. So I think many of you could recite these barriers, but Patience White, my colleague in crime, and I have spent a lot of time looking at the transition literature, and repeatedly, these are the main barriers that we see. First of all, that there is a lack of communication and coordination between pediatric and adult providers and systems of care. It's very hard for families and even pediatric providers of letting go of long-standing relationships. There are low levels of youth and young adults' knowledge of their own health, about privacy and consent, and how to use the adult healthcare system. On the adult health system side, the infrastructure support is very limited in terms of little care coordination support, limited information about community resources, including adult disability services, and poor access to adult mental health clinicians in particular. We also know that adult providers, the literature shows that they lack but want more knowledge and training in pediatric onset conditions and also about young adult health, and they want support from their pediatric colleagues. Now in red you can see major barrier is little time and low payment. So that's the barrier we're going to talk more about now. So next slide, please. So in particular, the literature often highlights that there are transition barriers, but often doesn't dig down deeper into what these barriers might be. So we're just offering a few sample examples of specifics. So we hear that there is a lack of recognition by payers of transition-related codes. For example, payers are not paying for care plan oversight or for transition readiness assessment or care management services, consultation, and self-care education. We also hear that the relative value units for these codes, for certain of these codes, are low or have not been published in the Medicare physician fee schedule. In addition, unlike the hospital-to-home transition code, which I believe came out in 2013, there is no comparable ambulatory care transition code. In addition, value-based payment efforts have been slow to think about pediatric to adult transition, either as part of their medical home efforts, care coordination, accountable care organization, population, or health homes. And another comment we hear is if the pediatric patient's last visit is a preventive office visit, the insurance will not pay for an initial adult preventive visit until a year later, which is obviously a disincentive for both the adult provider and the consumer. Next slide, please. Okay, so here is a frightening slide, but I'm going to try to break it down to be a little less frightening. These are the major transition-related codes, and we're going to kind of weave these codes throughout a set of typical transition planning services and a set of vignettes. So I think all of you are very familiar with the office or other outpatient service codes. These are your typical office visit codes. The office or other outpatient consultation codes are provided at the request of another physician. Again, these are face-to-face services. Preventive medicine services, you well know, are well care visits. And prolonged services can be either face-to-face or not face-to-face and are used when care extends beyond the usual service. Now let's go to the next little bucket there. The health risk assessment is quite a new code, and this can be used for transition readiness assessment, and I'll explain a little more for you shortly. And there is a code there, the 96160 is for a readiness assessment with youth, the 96161 is with parents or caregivers. The education and training for self-management code it sounds like a wonderful code, but it's limited to use with a standardized curriculum and must be provided by a non-physician who is trained to offer specific education. Now, looking at the next set of care coordination related codes, you'll see the medical team conference. This is with or without the patient present and includes face-to-face participation by a minimum of 3 qualified healthcare providers. The next code is a care plan oversight service. This involves a physician who is developing or revising a care plan and review of subsequent reports on the patient's status. The care management service codes that you see there involve clinical staff in developing, implementing, and revising care coordination plans, and is reported on a monthly basis. And the patient must have 2 or more chronic conditions. And if one bills for this, one cannot also bill for care plan oversight. The last care coordination set of billing codes are transitional care management services, and this is a bundle of face-to-face and non-face-to-face services for hospital-to-home transition, and the patients must have a condition that requires moderate to high complexity decision-making. And the final 3 codes there are for telephone services that are evaluation and management services to address an episode of care that is initiated by the patient and a visit is not scheduled within the next 24 hours. The online medical evaluation is, again, an E&M service in response to a patient online inquiry, and the communication from that must be stored electronically or in hard copy. And finally, the interprofessional telephone internet consultation is an assessment and management service when the patient's physician requests the opinion of another physician with specific specialty expertise. Now, in the handout that I sent to Maya, and hopefully you have, we have Got Transition put out a coding and reimbursement tip sheet, and these codes are in there with the 2017 Medicare values. We'll be updating this tip sheet in the next few months, but it's quite accurate. Very few changes happened in the 2018 CPT coding.
And Peggy, not to interrupt, but I do want to just let everyone know the handouts are available on our website under the Learning Community tab. 2018 and the presentation slides are there, as well as the 2 handouts that you're going to refer to in today's presentation.
Great, thank you, Maya. So it's really important. We also put the full documentation requirements that are in there from CPT code. Okay, so next slide. So let's just walk through some of the typical services that we offer in transition planning. Again, some of this is a little repetitious, but I want you to drill down and try this. So the assessment of transition readiness and self-care skills, you can use the health risk assessment code. You must use a standardized scorable tool, and the Got Transition tool is such a scorable tool. There are others out there, but you have to have it be a scorable tool. Also, you think about preparing and updating a transition plan of care for your patients requiring complex and multidisciplinary care. You can use the Care Plan Oversight Service Code. Again, this is for physicians. And then the self-care education, I think that the main potential is through existing evaluation and management codes for office visits to incorporate counseling into those visits. And finally, the education and training for self-management, that is really quite a limited code. So if you were offering, for example, you had a nurse trained in diabetes education and they were following a particular curriculum, that would be useful then. Next slide. So there's a lot of coordination of transition services that go on. However, you cannot use these codes unless your patient has 2 or more chronic conditions. And these can be used by physicians and non-physicians. So the first one is chronic care management services, again, for developing the plan of care and implementing and updating it. And this is 20 minutes of clinical time per month. And then the other complex chronic care management services involves a 60-minute time period. So if we can look next to the next slide, please. This is the transition from hospital to home. This requires a face-to-face visit within 7 or 14 business days, depending on if you use 99495 or 99496. And it incorporates a lot of non-face-to-face services, including review of discharge information, patient and family communication, interaction with other healthcare providers, and assistance with referrals. Next slide. This involves consultation to adult providers. This would be once the young adult gets situated with their adult provider, the pediatric provider can offer consultation to the adult provider. And I'm reminded that Medicare no longer recognizes these consultation codes, but other payers still allow them. In addition, one can code for interprofessional telephone and internet consultation. Next slide, please. So now to make these coding numbers come to life, I'm going to go through a set of 5 different vignettes, and hopefully this will be useful in terms of imagining your own patient. So this first vignette is a new 12-year-old male patient is just released from the hospital after a traumatic brain injury and has loss of consciousness caused by a serious car accident. The pediatrician communicates with the parent within a day of hospital discharge regarding follow-up treatment, and the physician reviews discharge information and needs for pending tests and physical therapy. The physician's clinical staff communicates with the physical therapist to coordinate a treatment plan and contacts the youth school to provide medical authorization for an extended absence. The pediatrician has a face-to-face visit with the patient a week following hospital discharge, assesses treatment needs and adherence, and provides education to this complex patient and parents. Now that is a transitional care management code, CPT 99496. And again, you'll see on the coding tip sheet how much could get paid for it. For an office visit under Medicare, that would be $234 in 2017, just to give you some idea. If we go to the next vignette, please. This is a more straightforward clinical vignette. This is a preventive medicine visit with a new 14-year-old female patient who has no chronic conditions. The physician updates the medical history, completes a physical exam, and provides anticipatory guidance as part of the well visit. The teen and parent separately complete a scoreable transition readiness assessment form, which asks a set of questions about the teen's self-care skills. In addition to risk factor reduction counseling, the physician also reviews and discusses a few of the youth-specific self-care skill needs identified by the youth and parent. So in this case, one codes for the well visit, the 99384. You include the modifier 25 because in addition to doing the risk factor assessment, there was also the self-care transition readiness assessment. So because 2 of those were done on the same day, you need the modifier 25. In addition, the 2 health risk assessments, the 96160 for the patient and the 96161 for the caregiver. Okay, next slide, please. So here we have an office visit with an established 16-year-old male patient who has moderate persistent asthma and is presenting with difficulties breathing and sleeping. He was recently in the ER for asthma complications due to inconsistent use of corticosteroids. And while waiting for the physician, the youth completes a transition readiness assessment form. The physician provides counseling regarding medication adherence and knowing his symptoms, including ones that he quickly needs to see the doctor for instead of going to the ER. During the visit, the physician also updates the youth's medical summary with the youth so that he better understands his treatment, and the physician encourages youth to add his medical information on his iPhone, given the patient often forgets his meds. The physician reviews the readiness assessment form and revises his plan of care to address needed self-care skills and changes in medicine. The total physician visit was 25 minutes, and after the physician visit, the nurse, who is a certified asthma educator, provides the patient with 20 minutes of education on asthma self-care using a standardized curriculum. So here you have 99395. This was a preventive visit for an established patient. Hold on. And then I'm sorry here. This should not have been there. That was a mistake on my part. This is not a preventive medicine visit. So cross out that in your mind, the CPT 99395. This was an office visit with an established patient at 99213 with a 25 modifier. And the 99358 also was for the prolonged E&M service before and after direct patient contact for the additional 20 minutes of education. So if we could go to the next slide, please. This vignette is a preventive medicine visit with an established 18-year-old female for her final pediatric visit before she goes off to college. She wants to see a new physician who treats adults, and she asks the physician for suggestions. She has been treated for major depressive disorder since she was 14, and during the visit, the patient describes high levels of stress associated with all the changes that are happening in her life and persistent sadness. The physician takes an extra 15 minutes to reassess her depression and determines that different medication is required. The physician reviews the last transition readiness assessment conducted when the youth was 17, updates her medical summary, and recommends an adult physician who can accept her as a new patient. He also recommends that she schedule a physician with her child and adolescent psychiatrist to discuss her depression and her transfer plans to an adult psychiatrist. Following the visit, the physician takes an extra 30 minutes of non-face-to-face time to prepare a transfer letter for her to take to college and to her new adult physician that includes an updated medical summary, plan of care, and transition readiness assessment. So the coding for this is a well visit 99395, an office visit with a 25 modifier because of the two separately identifiable activities that were going on in both the preventive and the identification and treatment for the major depressive disorder, and to cover the added non-face-to-face time, the prolonged E&M service code of 99359 is used. Next slide. Okay, vignette number 5. This is an office visit with an established 20-year-old female patient with spastic quadriplegia due to cerebral palsy. She has a seizure disorder and depends on a motorized wheelchair for mobility, an iPad for communication, and a gastrostomy tube for nutrition. During the regular chronic care visit, the physician spends 40 minutes with the patient and assesses her level of readiness for an adult model care using a transition readiness assessment form, reviews the enteral formula she's using, and reconciles her seizure medicine. The physician talks with the young adult and parent about timing for transfer and adult provider preferences. The physician suggests a new adult doctor to transfer, and the young adult, though not her parent, is eager to transfer to adult care over the next few months. You always want to put a little humor in here. The physician discusses with the young adult and parent the actions that need to take place prior to transfer, including coordinating transfer plans with her providers, preparing an updated medical summary and emergency care plan, and consulting with the new adult doctor. The physician spends greater than 50% of the visit counseling, and following this last pediatric visit, the physician and clinical staff devote an additional 60 minutes of non-face-to-face care management services to prepare the transfer letter, contact the young adults, other specialists to coordinate transfer information, consult with a new adult doctor, and call the young adult to review final plans for transfer with date for the initial appointment. So you can see the highest level of an office visit at 99215, the health risk assessment, and the 99487, the complex chronic care management service. And let me just tell you, if I can quickly find it, how much that would have been paid for in the, and that would be a $93.67 under the 100% Medicare fee in 2017. Okay, next slide. This is our last vignette. Oh no, that was the last vignette. Yeah, no, go ahead. We're good. So I want to also, we've spent a lot of time looking now at the CPT Medicare fee schedules that a lot of commercial payers use, and also Medicaid. But in many states, the Medicaid agency has their own fee schedules. So I encourage you to look at your Medicaid fee schedules to see if there might not be, if these codes are recognized, or if other, for example, you might have different case management codes that might be relevant. And if they're not there, we encourage you to advocate for these transition-related codes with the Medicaid office. Next slide, please. So I often use this slide from Dr. Joel Bradley, who is on the AAP's Committee on Coding and Nomenclature. Many ask, why do I bother coding for what you can't get paid for? And he said, the only code that you can't ever get paid for is the code you don't use. And the only way to get paid is to negotiate. And the only way to negotiate is with data. So no coding, no data, no money. So even though it's terribly frustrating to spend the time using and documenting for these codes, we're hoping in the long run it will pay off. Next slide. So in your handouts, we have a letter template that we did with the Academy of Pediatrics that can be used by practices or hospitals or AAP chapters asking Medicaid and commercial payers to recognize transition-related codes that are not covered by your payers. And so you can use that handout as a template and identify which of the codes are not being covered, and hopefully you will have some success in your advocacy efforts. Next slide, please. So now I'm going to leave conventional fee-for-service land and talk to you more about future payment directions around value-based payment. And it appears that Wisconsin is involved in a fair amount of work in this area, as are other states. So there are certainly a range of payment methods and pulling in value, and are often linked to quality metrics with adjustments for complexity. So I'm going to talk about 4 payment alternative payment methods: enhanced fee-for-service payment, capitation, episode of care, and pay for performance. And I think it's important, as the slide way early on said, very few people have considered pediatric to adult transition in their value-based payment strategies. While most have thought about the hospital-to-home payment or delivery system improvements and linked that to payment changes, we haven't really seen much in the way of pediatric to adult. So when I'm introducing this, I'm encouraging you to talk with your contracting offices in your practices, to talk with your health plans and payers to see if there might be some opportunities to pilot some innovation here. Next slide. So the first idea is thinking about using an enhanced fee-for-service option. And we've seen this in a few states around where there are access, for example, shortages in pediatric subspecialists, where a given state might pay a higher evaluation and management fee to those physicians who are in short supply. So as kind of following that model, we're suggesting one could consider, since we know it's very difficult to find adult doctors who are available to accept young adults with chronic conditions, to think about increasing the E&M office visit fees to, let's just say, 150% of the Medicare value. Another strategy would be also to do a similar up the E&M fee for both pediatric and adult doctors for the year before and the year following transfer, recognizing that both sides of the bridge have a lot of added work involved in making this transfer successful. So that's an example of what one might consider. Next slide, please. I want to say that a lot of health plans and Medicaid agencies are in the business of capitation and using per member per month strategies, whether it be for looking at entire the full swath of what an individual would require, or just looking at care coordination on a monthly basis. So another strategy would be that the payers could provide a monthly care coordination payment, again, for the year before and after transfer, adjusted for complexity for both pediatric and adult practices. And with that, per member per month, on the pediatric side, you could prepare youth and families for transfer, prepare the necessary transfer documents, ensure coordination and communication between both pediatric and adult providers. And on the adult side, they could be doing more proactive outreach and facilitated access, and ensure the appropriate referrals and connections to adult specialty, behavioral, and reproductive care. Next slide, please. Another alternative payment idea is using an episode of care, an approach where you're bundling a set of services. And certainly we see this for a lot of adult specialist areas and increasingly for perinatal care. So in this way, payers could create a payment for a combination of services provided by the pediatric and adult physician and other qualified healthcare providers triggered by the plan transfer. So think of the transfer as the episode of care, and you would look at what would be happening prior to the transfer and then after the transfer. So you can imagine thinking about the last pediatric visit, a face-to-face visit, and the non-face-to-face work that is involved in the preparation of the transfer package, the education of youth and families, and the communication and coordination with the adult provider. And on the adult side, the added work involved with making that initial adult visit a golden visit, a review of the transfer package, a welcome and orientation of new young adults, and communication and coordination with a pediatric provider, and then often linkages to other needed specialists. Next slide. The last example of an alternative value-based payment method is a pay-for-performance strategy. This would involve payers creating incentives that would be linked to agreed upon performance metrics. So one example might be you create a bonus payment for pediatric physicians transferring the young adults before the age of 22 with up-to-date medical summary, evidence of communication with the adult doctor, and the initial visit made within 6 months to a year after the last pediatric visit. And then a bonus payment for the adult physicians who would accept a certain volume of young adults with chronic conditions, receiving pediatric consultation, and achieving certain patient-specific outcomes. Again, these are just ideas that we're floating out there because we really would love to see more providers, practices, and health plans doing some piloting of this work. Next slide. So what's very helpful, I think that it's been our experience, is that one needs to piggyback on existing efforts that are going on. So to look at what value-based payment strategies are currently underway with your area, your Medicaid commercial payers and health plans, and see if there's an opportunity to piggyback or expand on these to include transition. For example, they might be doing a great deal on care coordination or health homes. How can you grow that out and create a payment strategy that would make pediatric and adult providers feel that their work is valued? So any opportunity to begin a new partnership to pilot a value-based payment strategy, I think one really needs to think about this not just as a pediatric provider, but as a constructed bridge. So if you, for example, you are a children's hospital and you are suffering because you don't have a sufficient number of adult providers to receive your patients, what about thinking about a partnership with a federally qualified health center or an adult hospital or a large family medicine or internal medicine practices, and coming forward with a kind of collaborative effort to a payer or a plan and see if they might not be interested in piloting this kind of a strategy. Next slide. So when we think about value-based payment, and you can't go in that zone unless you're thinking about quality metrics. And our conversations with payers suggest that obviously they care mostly about cost, but keeping in mind the triple aim framework of population health, utilization and costs, and patient experience are very important. And we also like to have, when you think about metrics that make sense on the pediatric side, that make sense related to the actual transfer process, and that makes sense on the adult side. So here are some examples for you to think about for population health, about the preparation and exchange of a current medical summary, medication reconciliation, and preventable complications. You know, it's always wonderful to work with patients who have diabetes because you can look at A1Cs, but that's not a common indicator. It's hard to find these common indicators to show adherence to care, but think about preventable complications. Utilization costs, you could look at the initial adult visit within a specific period of time since the last pediatric visit, and hopefully you're trying to reduce that. And I think from the review of the literature that we've had, for those with chronic conditions, if that period of time is longer than 6 months, outcomes are worse. Oh, hold on, back up please. Yeah, and then obviously you could also look at preventive care visits or primary ambulatory care visits, ER and hospitalization. And finally, you could imagine looking at satisfaction with transition preparation, transfer, and integration. And on our Got Transition 6 Core Elements package, we have a sample transition feedback survey that could be used. Next slide. So I wanted to make sure that you had on your fingertips the AAP coding hotline. I have often received coding questions about particular patients, and we really at Got Transition are not in the business of providing that kind of advice. So please reach out to the AAP coding hotline for those kinds of specific questions. They do wonderful coding webinars, and the AAP chapter in your state, I believe, has or had a pediatric council, and they do a lot of work around advocacy with payers. And then the AAP national office has a committee on coding and nomenclature who have been terrifically helpful in our work, and their committee on child health financing and private payer advocacy. And with respect to our office here, we are going to be having a May meeting of commercial and public payers. We have had interviews with over 60 thought leaders in this space, trying to identify what are the pros and cons of various payment strategies and quality metrics so that we can start to put out a set of recommendations, and hopefully more payers will adopt them. And we'll be coming out with an updated reimbursement tip sheet in late spring. Also, we've excited to work with the University of California, San Francisco. They have a national adolescent and young adult health information center, and we put together a toolkit on incorporating transition into the adolescent and young adult preventive care visit. And that will be coming out in September. And last but definitely not least, my colleague Patience White has been leading the update of the clinical report, and we hope in the next several months that that will be released. Next slide, please. So just please take a moment sometime and visit our website. There's a lot of resources, not only for healthcare providers, but also for youth and families and researchers and policymakers. Next slide. So in sum, I hope from this presentation you walk away having a better idea of the payment barriers, the relevant CPT codes, some options that you might want to think about for value-based payment, and that you understand some of the resources that are available at the AAP and Got Transition for payment. So I thank you very much, and I look forward to your questions with great trepidation. Thank you.
Wonderful. Well, thank you very much. That's a great amount of information, and I find all of the resources that you're talking about in the upcoming months to be very interesting. At this time, I want to open it up for everyone to ask questions.
While we're waiting here, I also want to just let people know that Maya certainly knows our email address, and if we can be of any assistance following the call, when you pop up with another question, or if you've got an idea for a value-based payment option, we're really eager to think with you about strategies in that area.
I realized I had not progressed to the last slide, but I loved the, the little picture of the girl with the glasses and the sleeping.
It's especially a good slide for payment.
It is. And I think that that was part of one of your final slides where you just talked about some of the meetings that are coming up. That one in May sounds like it's going to be a rather intense conversation. Obviously conversations that have to take place, but one that's going to be a very well-informed group of people who are going to be talking about coding.
Well, it's really a lot about value-based payment strategies, and we will have, I want to say, 3 or 4 major commercial carriers, 3 or 4 state Medicaid directors, CMS officials, representatives from the AAP, AAFP, ACP, and various payment researchers. So it will be, I think, a very pivotal meeting for our field, particularly since we're all very early on in this innovation, and we want to jumpstart it, and hopefully they'll help us think through strategies for jumpstarting.
Great. We do have one question coming from Sharon. She says it's a wonderful presentation and wants to know if you are aware of commercial payers who have been most interested in value-based payment options.
Oh, thank you, Sharon. The value-based payment work is just, seems like it's taking off like a fire. I was at a meeting in Denver this past month with many commercial payers and health plans working in this area. The reality is they're not working on pediatric to adult transition. So, we're trying very hard to bring some of those to the meeting to say, do we try to sell this through your PCMH efforts, through your care coordination efforts, through population health, through hospital to home transitions, how do we piggyback on your efforts? And so that's why when introducing the slides that I gave, I encourage you to start having some of these conversations, because the one thing that came across in this meeting of payers was that they really are trying to build new partnerships with provider community, and wanting to work out solutions that make sense clinically as well as financially. And so to bring some of these problems that are so pervasive in terms of I don't have anywhere I can send my patients to, and creating a planned, structured process where you have an agreed partnership with an adult provider or system, and kind of use the model or the approach of the 6 core elements. And your Wisconsin quality improvement efforts have done so well in this area, that is a way to implement this, and to imagine how with the payer you could structure payment that would benefit both sides and achieve the end that you're all wishing for, which is a smooth, continuous pathway from one system of care to the next. And God knows you can tell the problems, but the question is, can you pull together the partners, and can you rely on the adaptation of the core elements to show that you have a delivery system improvement method in place on both sides to make this work? And I think, Wisconsin is, as I think of many states, is quite far along. So I really strongly encourage you.
Great. I think that's a very good answer. Sharon just added that the one area where we have been successful for payment of care coordination to include at least some pieces of transition, it's for children with complex care needs. So it says I should add this to the Wisconsin MA program.
So imagine if you had, you're invested in care coordination, but there's no specifications around the transition planning, transfer, or integration into care. How can you lay that out in terms of contract requirements, quality metrics, and payment, so that it is not hidden from the overarching payment structure?
Well, I know this was quite a bit of content for everyone. Peggy, thank you very much for your presentation. It definitely gives us some things to think about. As Peggy mentioned, I do have her email and would be happy to forward any additional questions after maybe some processing time of the information. As I mentioned, all of the materials will be available, as well as the presentation, later on our website. So we appreciate that you were able to make this time work to talk to everyone here in Wisconsin. This does conclude our presentation, and we look forward to seeing you at our next learning community. So with that concludes our March learning community. Thank you for everyone who has spent their lunch hour with us, and we look forward to seeing you at our next presentation. Thank you.